Welcome to AETCM, the emergency medicine channel. Today we'll be discussing a case of a young guy who presented to us with decreased sensorium. Can we begin, sir?
Yes.
35-year-old male with who's only a known case of dyslipidemia and nothing else was found to be lying down in the bathroom with decreased sensorium at around a couple of hours ago before presenting to our hospital. And mechanism of fall isn't known because it was in the bathroom. It was not a witnessed fall. And then he was taken to a local hospital wherein he was evaluated and then brought to our hospital with a running diagnosis of icy bleed. So on examination, our initial 10-second assessment, patient was only responsive to pain. Then primary survey airway was patent for now, but patient had to be in. But since patient had decreased sensorium, it could get compromised at any point in time. Tongue fall could be there, but there was no anatomical deformity, no obvious injuries over the face, and so we moved on to the breathing part. But that had to be monitored. Airway compromise was still a query thing, but at present it appeared patent. So breathing, a patient had bilaterally equal air entry with a respiratory rate of 18 cycles per minute, maintaining
What is the
saturation.
position you will keep the patient up? You are receiving a patient. From that time itself, your duty is receive everything. So what is the position?
So patient will be in the head would be elevated because we would have there's running diagnosis of icy bleed, and if at all patient throws any seizures or anything, it will be in the left lateral position, but it will be semi-flexed.
That's right. Before giving a head up tilt, what is the most important thing you have to look for?
Any injuries on the
that is the routine for the trauma patients. Blood pressure.
Blood pressure.
See, already the patient is in low BP. So your head up tilt may further worsen the condition. Okay.
So then respiratory rate was 18 cycles per minute and saturation was 98-99% in room air. With moving on to the circulation, patient had a heart rate of 82 beats per minute with a blood pressure of 220/100, and all peripheral pulses were palpable and rhythm was regular in nature. And then disability wise, he had a GCS.
You have to always tell mean arterial pressure. That is.
It will come up to 80 plus, sir. Disability wise, GCS.
So what is the target MAP?
In cases of raised ICP, it will be 80. If you're not dealing with head injury or any intracranial pressure, it will be above 65. But in this patient, it will be above 80 is what we have to maintain the cerebral perfusion pressure. Then disability, GCS was E2, V2, M5.
The systolic BP is very high.
Systolic 220, diastolic 100.
100.
Disability, GCS is E2, V2, M5, totaling up to 9 on 15. So pupils were 1 mm, bilaterally reactive, but it was sluggish in nature. And there was no obvious injuries noted on the extremities. And patient was able to spontaneously move his extremities, even though power could not be assessed. And exposure wise, temperature was 98.
Clinical examination, this type of case are very dangerous because you manipulate the limbs, you give pain. That all will be a stimulus for the raised ICP. So once you know that it is raised ICP, better not to touch the patient unnecessarily.
Then exposure wise, he had a temperature of 98.7 degree Fahrenheit with the blood sugar levels of 103 milligram per deciliter. Now patient had a GCS of 9 on 15. So it was a borderline. Anything less than 8 and below, we intubate. We go ahead with rapid sequence intubation.
In this patient, suppose you want to intubate, what all precautions you take?
One, this is a case of raised ICP, sir. So patient also has increased blood pressure. So the idea behind whatever preparation we make is not to further increase the IC bleed. So first thing would be the positioning, like sir asked, it will be head and elevation.
30 degrees.
30 degrees. Patient will be put in a semi-flexed position, and then no neck lines would be used for cannulation, and adequate suctioning further increases IC bleed. Avoided. And unless until is absolutely mandated. And then if there is tongue fall, then patient has to be put on a NPA because this patient is semi-conscious. So NPA has to be put in, and then we plan for intubation. So adequate analgesia has to be provided for this patient because further pain will further increase the IC intracranial pressure, and blood pressure also has to be brought down. And because we knew this is an IC bleed, and it will become an hypertensive emergency in this case, so we'll rapidly bring down the blood pressure and maintain a target of 140/90. And then when we're moving on to the preparation, this is then to the drug agents that we will use. In pre-medication, an opioid can be used, that's a fentanyl, can be used in order to provide adequate analgesia.
Should be used.
Yeah,
Okay.
should be used.
Must. Adequate dosage.
Adequate
No
dosage.
question
has
of
to be, yeah.
smaller dosage. Okay.
Then in the induction agents, etomidate or propofol can be used in this condition because propofol also has an added advantage of anti-seizure property. So propofol can be used, and ketamine can also be used.
Ketamine.
Not ketamine, etomidate.
Ketamine. Okay.
Previously, ketamine causes further increased IC bleed and tachycardia, so it is best avoided, even though it's not a absolute contraindication. But preferred agents would be etomidate and propofol.
But here in this patient, BP is very high.
Very high.
Every additional 10 millimeter already can cause more problem. So ketamine better we can avoid it. Okay. Good.
Then in paralytic agents, any paralytic agents can be used like rofuronium, atracurium, even suxamethonium can also
You
be.
are planning for RSI or elective? Planned.
And it would be idea would be a elective thing, sir, because patient is bordering on 9 on 15. But while we are taking the patient for a surgical intervention, at any given point, if the patient sensorium drops, then it will become an RSI.
Okay. So RSI means for the different muscle relaxants and induction agents. Because here we have to use either succinyl choline or rocuronium, the quickest onset, right? Shortest duration of action of the drug.
Yes, sir. So BP and analgesia would be the mainstream of management in this patient. And
How
then
do you control the BP in this patient?
Now 1 minute. See, with this patient, I didn't able to catch your history. What is the events happened?
So event was this patient was last seen normal while he was having his breakfast, and then when he went to take a bath in the afternoon, he did not really come out of the bathroom. So because of which the bystanders, the family members got a little tensed. Went knocked, there was no response. When they broke open the door, he was found to be lying down on the bathroom with decreased sensorium, and he was not responding.
Okay.
So, because they could not understand what was happening to him, they took him to a local hospital where an emergency
Do
CT
you
was done.
suspect any C-spine involvement in this case?
It cannot be ruled out, sir, because it was an unwitnessed fall.
Okay.
Either he could have slipped and fell in the bathroom, hit his head against a tap, commode, or whatever, or he could have had a syncope and then fell. Anything is possible, so it cannot be taken for granted that there is no C-spine injury. Because patient sensorium is low, patient won't be able to tell if he has any neck pain. So an imaging has to be taken and ruled out a possibility of a C-spine injury.
See, until you rule out the involvement of C-spine, we have to either manually immobilize or we have to put an appropriate C-collar. So with that we have to proceed with the patient positioning, pre-oxygenation, intubation positioning, or airway maneuvers, everything will be going along with this one. Okay. And number 2, you told that the patient has been taken to another hospital. So how long it was the duration of delay from the time the incident took place and
it was roughly about 3 to 3.5 hours.
3 days. In the meantime, there should be or might have been some sedative drugs, whether the other hospital has given or not. So in that case, do you suspect or anything is from the reports we find out, we have to reduce the dosages of our drugs, what we are giving. And previous history of any hypertension, whether medications for hypertension or seizure or syncopal attacks, anything keep in mind. Okay. Because hypertension, anti-hypertensive drugs, in addition whatever hypertensive drugs plus anesthetic drugs, profound fall in BP may be there. Okay. So other hospital might have given any parental antihypertensive agents. So along with our drugs, definitely, for example, is told propofol, potent hypotensive causing drug.
Continuing to that, sir, patient has a very strong history of family history is there of hypertension, but he was only documented to have dyslipidemia. He was not previously known to have any hypertension comorbidity, so he was not on any medications. Since the BP was high and it was retrospectively thought that the patient perhaps was a case of undiagnosed hypertension.
Is he shows an LVH?
Patient, according to the criteria, he does not have an LVH. But there was that tall waves are there. And patient was not into bradycardia yet. So,
What does it mean, bradycardia?
sir, it's a Cushing's reflex wherein a patient will have irregular breathing pattern, hypertension, and bradycardia. That signifies raised ICP.
Oh.
So the patient was not having this
Only hypertension also.
bradycardia. It was just the hypertension bit.
Any external visible obvious injuries?
No, sir. No, sir. That we screened through because the mechanism of fall was not known. So we screened through everything. Oh, that's
We were opting for nasopharyngeal airway. When this BP is very high, please keep in mind there may be chance of epistaxis also on the tissue.
Then moving on to the adjunct to our primary survey, ECG was taken and ruled out bradycardia. We did a ABG. The idea behind was to rule out any hypoxemia, and because the patient had decreased sensorium, possibility of PCO2 retention had to be ruled out. But this patient did not seem to have any acid-base derangement, and lactate was also on a higher normal end of the higher range, like about 2.3.
Lactate, high lactate indicates what? In this case,
Again, hypoxia can cause lactate,
hypoxia can
or
produce.
ischemia can cause
One more
or
important,
seizures.
Seizure is most important thing. Somebody is coming with altered behavior, suspecting bleed. If lactate is very high, then you have to strongly suspect seizure. Okay.
And then clinical examination wise, patient was only responsive to pain. Much of CNS examination could not be done, but bulk and tone appeared to be normal. He was spontaneously able to move his limbs.
If you are thinking bleed, you should not examine the patient. That is the best thing we can do in emergency room, because we keep on trying examination, patient may deteriorate. If you are suspecting bleed, give essential treatment in ER, take CT scan. That is the best thing we can do. Try to avoid more harm to the patient.
And chest was auscultated to rule out any aspiration. And then blood sugar levels were checked and it was normal. So temperature 98.7 degree Fahrenheit.
So what are the important things which can trigger the problem in a case of bleed in your brain? Trigger means it can deteriorate. Factors which can deteriorate the patient who is having intracranial bleed.
One further pain.
Important is pain.
High BP, uncontrolled
hypertension.
BP. Then
high degree fever, temperature,
infection.
blood sugars. These are the things we have to control. So pain should be controlled, BP should be controlled, then temperature should be controlled, sugar should be controlled. Okay.
So because we did not really have much of idea on details on the CT brain scan and all of it, it was just written in a referral letter that it was an IC bleed. Okay. So we had to repeat a CT to get more idea about the patient's condition. So the patient was transported to a CT room, but low sensorium, so a doctor had to accompany, and a crash should be anticipated, and the patient should go with the crash cart equipments. Then
in such cases, better intubate and take the patient. So this is a setup where you have got all facilities, including personal help. See, when you are there is a dictum also. Whenever you anticipate anything may happen during CT or MRI, please put an endotracheal tube and safeguard the.
Okay, sir. Then CT showed a massive left-sided gangliocapsular bleed with midline shift and interventricular extension. So there was a massive bleed which needed to be addressed. So we involved the neurosurgical team, and the patient was planned for emergency decompressive craniotomy procedure. So then after that, the patient underwent the surgical procedure. His GCS was monitored every 15 to 30 minutes. There was no further drop. Pupils were also checked, and then the patient successfully underwent the procedure, and it was uneventful. And then he was brought back and extubated, and then we are monitoring again his GCS and his pupils along with blood pressure.
How do you manage the BP? Because anyway, procedure has to be done. Immediate procedure save the life. Okay, but we have to control two important things. One is we have to control the BP. Second one, we have to control the raised ICP in ER itself. These are two things we have to do, and control the triggers like whatever we discussed: temperature, hypoxemia, hyperglycemia, all the pain, all these things. How do you control the BP?
So, in BP, because it's a young undiagnosed case of hypertension, an aspect for evaluation for causes of hypertension has to be kept and not ignored. But at present, to control the BP, a beta blocker would be a choice, a preferred choice like labetalol. Injection has to be given about in increments of 10 mg, then repeated of 20 mg up until in total of 40 mg in total, and then we can start on infusion at 1 to 2 mg per minute, and then we titrate according to our desirable blood pressure. But ideally it is 10 to 20% of the patient's blood pressure has to fall within the first 1 hour, and then the rest has to be brought, the target has to be achieved in the next 5 hours. But this is an hypertensive emergency, so we wouldn't be wrong if we rapidly bring down the blood pressure, and it has to be monitored to 140 over 90.
Okay.
And that would be our target.
What are the here? Labetalol has got some advantage. It has got both beta and alpha blocking action. Predominantly, it is beta blocker. But if other drugs like beta alone, like what is that drug? Metoprolol. Okay. What are the problems of metoprolol in conditions like this? Why nowadays only labetalol is advised?
One thing is we don't know the etiology of the patient. If it is like a pheochromocytoma, both the alpha and beta will be active. So if you're giving only beta blockers, the alpha hormone will be more aggressive and can again increase the beta. Also, if the patient has history of any cocaine abuse or anything, it can again worsen the condition for giving beta blockers.
So two important things in a young patient you have to remember. One is cocaine abuse induced high BP and pheochromocytoma. We don't know at present whether this patient is having such problems or not. So either you have to give alpha blocker with beta blocker, or you have to go for a drug like labetalol, because nowadays that is the only major recommended drug in almost all types of hypertension, because it has got both alpha and beta activity. But it is predominantly it's a beta blocker. Okay, we have to be very careful.
Then along other than this, we can use NTG also can be used.
NTG can be safely used.
NTG can be safely used. And then once
How to control the raised ICP? Second question. First is control the BP. That has to be done because it's a bleed. It is not an ischemic stroke. Okay. Here also, but we had, if you reduce the BP drastically, here also that ischemic penumbra problem can occur. But here little more liberal approach you can give. You can give more reduction, like she told. How to control the raised ICP? That is the second question. It's only bridging therapy. You have to take the patient for surgery definitively, but in between you can try to control the raised ICP for a short span of time. How do you control? And keep on giving the drugs for this is also wrong.
We have a pharmacological and non-pharmacological measures for this. Under non-pharmacological is what we discussed, when we'll have that head and elevation, we won't prick the neck veins, we'll control the patient's BP. If the patient is awake, then anxiety has to be controlled. In the pharmacological aspect, a patient can have a cerebral bleed, so 3%, a hypertonic saline, like 3% saline has to be initiated. And the sodium levels are to be kept on the higher range. The target will be 145 to 150 milliequivalents per liter. So we'll initiate the patient on 3% saline. And if the patient has
percentage of saline you want to increase?
3%.
3%.
3% saline.
So in the
Hypertonic.
case of hypertension, to this extent of 200 and odd, what is the rationale behind starting hypertonic saline?
Hypertonic saline basically is an anti-edemal measure, sir. It will reduce
for this patient. You have to be very safely play a role. Okay. Take care of it.
And other agents like mannitol has to be used 20%, 100 ml. Now it shouldn't be given in the slow infusion. It has to be pushed bolus within 5 minutes. Mannitol 100 ml.
What is the dose of mannitol?
100
This is 1 gram per kilogram. Over 1
Minimum is 1 gram per kilogram. That has to be given over
hour.
1 hour. So 1 gram, each mannitol contains how much grams?
20 gram.
20 grams. So 70 kg or 75 kg require at least 3 to 4 bottles of mannitol to be given over 1 hour. That has to be given. Okay.
So hypertonic saline, mannitol would be the preferred agent.
Like sir told, hypertonic saline, we have to be very careful. Like in hypertensive patient, it can further increase sometimes the BP. There are two types of BP. One is salt dependent BP, other one is salt independent BP. Salt dependent means definitely it is going to increase. That we have to be very careful when you are giving 3% saline. If it is, there is a definite benefit only, we should give. Okay, because all these things are transient effects. So you are taking this patient for major procedure, neurosurgical procedure, all these things may not be required only. Okay.
Then the next
Third one is very important because sir has already told you, you might have noticed better to intubate this patient and send for a CT scan. So after intubating, what he can do?
continuous sedation.
No. This to reduce the ICP. Is there any way to?
One is when hyperventilate the patient.
Hyperventilation is the easiest thing.
PCO2.
Okay, but that also short-term benefit. Continuously you cannot do hyperventilation. So all these measures are only short-term. There is no point in continuously giving mannitol, 3% saline, hyperventilation. All these things are wrong practice. Anyway, you are taking this patient for procedure, he will definitely improve. Okay, after that there is no point in continuing all these things. Steroids, any role? What type of brain edema steroids are useful?
That metastasis.
Any tumor induced edema, steroids may be helpful. Otherwise, it is not at all useful.
Then the next aspect is seizures. Previously, the school of thought was to start the patient on anti-epileptic drugs regardless. But now studies have shown that only if the patient has past history of seizures or after the event of the patient has an episode of seizures is when we have to start an anti-seizure medication. Otherwise, starting directly just because there's a bleed, there's no indication to start an anti-seizure medication. Then
but if you see many patients with intracranial bleeding, doctors definitely start because they anticipate a seizure. You cannot tell it is wrong. Okay. But studies have shown that there is no need, but many doctors still give anti-epileptic drugs early itself as a preventive this one.
and then
See, regarding the outcome of the patient, there are 3 criteria which should be avoided. I mean, based on that only the patient outcome improves or deteriorates further. Any one bout of hypotension and any one bout of seizure and any one bout of one more thing is there.
Hypoglycemia, hyperthermia.
No, sir, one more point. You remember?
anisochronic.
Hypotension, hypoxia.
Hypoxia.
Hypertension, and then seizure one episode.
Seizure is very important.
So, prophylactic seizure, anti-epileptic drugs is better, but I don't know what is the recent concepts, why they are doing.
It is debatable. So some says it is not useful, some says it is useful.
Okay. But regarding the ABG, what is the initial baseline ABG value?
No acid-base arrangement, sir.
You did an ABG or VBG?
We took an ABG because we had to even see the PO2 level. Patient had low sensorium, so to rule out
PO2
hypoxia.
level.
PO2 level.
What is the PCO2 level?
PCO2 level was 43.
43. See, this here PCO2 is also important or not?
Yes, it is. Because hypercapnia, hypoxia, again further hypercapnia can cause CO2 narcosis. Patient sensorium will further drop.
See, what will happen to cerebral circulation when they hypercarbia?
Hypercarbia causes vasoconstriction.
Vasodilatation.
Dilatation.
It will cause vasodilatation.
CO2 causes
So again cerebral blood flow will be increased, it will worsen this one.
I see bleed, correct.
That's why we always hyperventilate. Hyperventilation will cause vasoconstriction.
Then apart from this, patient has to be thoroughly screened for, extensively evaluated for the cause of hypertension, whether it is primary hypertension or secondary
So you
hypertension.
take the
because it's a young
patient, give oxygen, put the patient on 30-degree angle, start mannitol, 3 mannitol should be given as a bolus, shift the patient for CT scan. And if needed, like sir told, better intubate the patient as soon as possible, because we cannot, while shifting, lot of unwanted problems can occur to the patient. And seizure prophylaxis, like you told, at present there is no guideline says that we have to start, but it is better to start from our experience.
So in our examination wise, even renal Doppler was also done. That came back to be normal, and the patient in the post-operative phase is getting better by the day.
So this patient is a young hypertensive patient. One problem you have settled, the patient's acute problem you have settled. You have started treatment for hypertension, labetalol. How do you continue the treatment of hypertension in your ICU? What all things to be ruled out?
One patient should pheochromocytoma
Pheochromas should be ruled out. Can we rule out pheochromocytoma now? We have already started beta blockers, so there is no point in sending the testing for pheochromocytoma. Like, what are the testing to be done? VMA and metanephrine. It will be difficult. Either you have to stop beta blocker and wait for 3 days and send, or you can go for scan. What is that scan? Nuclear medicine scan. That will pick up the pheochromocytoma. So, but at present patient is not good. Second thing is Conn syndrome. How do you rule out Conn syndrome?
Cortisol levels, aldosterone levels.
Aldosterone. Renin aldosterone levels. Okay. So Conn syndrome, what happened to the renin? Renin aldosterone?
It goes.
Renin will be low, aldosterone will be high. Okay. Whereas in high renin hypertension, because of kidney tumors and all, renin will be high, aldosterone will be low. Then third one is, like you told, Doppler, renal Doppler. That is one of the most important cause for secondary hypertension in young adult. Okay. So that we have ruled out. No?
And any abuse?
Drug abuse, cocaine, amphetamine, like that. That they have not given any history. We have to ask the patient. Now patient is still unconscious, so we cannot take. But urine
Substance abuse, we did send for screening, so came back
substance
to be
abuse is
negative.
negative. Okay.
So then heart can be, screening echo has to be done
Okay.
to rule out any valve deformity, concentric LVH.
LVH. Valve deformity. What valve deformity? You are suspecting somebody is having
Aortic
aortic dissection.
AR.
AR.
can cause hypertension.
Young age. What AR you are suspecting? What is the cause for AR in that? Suppose it is in young age. What will be the BP in AR?
High
High systolic BP, low diastolic BP. So pulse pressure will be very wide. That is not there. Here diastolic BP is also very high. Okay. So AR is out of question, but if you want to think, then you have to think about aortic problem. Okay. Aortic root dilatation, AR, hypertension, like that.
And then eye changes have to be checked for ophthalm because it's a young patient, diabetic retinopathy.
Hypertensive.
Not
retina.
hypertensive retinopathy has to be ruled out. So
What will be the now once the patient is stabilized, you have to put the patient for oral antihypertensives. What antihypertensives you start for this patient?
start on hydralazine or calcium channel blockers,
What is the ideal drug here?
ARBs, ACE inhibitors, beta
This patient is having LVH, left ventricular hypertrophy.
blockers.
You have to start on AC inhibitors or IRBs. That is a first line drug. How do you treat the hypertension? ACD. ARB or AC inhibitor, calcium channel blockers, diuretic. These are the three things should be started as first line. Beta blockers can be started if there is a compelling indication. What are the compelling indication for beta blockers?
Previous cardiac history.
Cardiac disease. Then ischemic heart disease, cardiac failure, like that. If that is not there, there is no point in starting beta blocker as a first line drug. Can be add-on drug. But here we have started beta blocker as an anti-hypertensive in acute phase. Okay. What happened to the patient afterwards? So you have to start AC inhibitor ARB if there is no elevated creatinine. You have to start AC inhibitor or ARB. That is the best drug. Or calcium channel blocker. Okay. What we have started after that?
We have
He is on cilnidipine.
cilnidipine.
Okay.
Then post-procedure, patient has to be even monitored for infections. Patient can end up with encephalitis or meningitis, or any infection can happen, or hospital acquired infection can also
If
develop.
the patient develops meningitis, what is your preferred drug to treat that?
Ceftriaxone 2 grams, along with that
If the patient develops an infection
vancomycin.
inside hospital after a procedure, you have to cover MRSA.
Vanco.
So that has to be started. Okay. No, unfortunately, most of our patients, they don't develop meningitis after this type of procedure.
So all this has to be screened for with blood sugar levels, blood pressure, then infections, everything has to be ruled out. And DVT prophylaxis has to be given and nutrition has to be checked. And because it will be a long stay, then bed sores, leg physio, all that has to be done. Now this patient's GCS is improving. So far he is showing good prognosis. Probably in a couple of days we'll discharge him.
Okay. Anything else you want to add?
This one. Anyway, if you're intubating the patient, actually, if you're giving mantle, you have to catheterize as early as possible because a diuretic patient. And also, post intubation, he should be completely sedated and paralyzed. There should not be any triggers in the ventilator post this thing throughout until he was taken for surgery because again, it can increase the ICP. And also, we have to also control the sugars and hypoxia. Everything should be controlled, monitored. Also, post procedure and also during procedure, also we have to maintain the basic physiological hemodynamics. That is, oxygenation should be properly maintained. Between about 92 at least we have to maintain. Then glycemic control should be maintained. Blood pressure should be controlled. Then we have to prevent any hypothermia or hyperparaxia should be controlled. And also we have to control any triggers like any movement, any pain, any suctioning. Everything should be minimized as much as possible. And also this thing, as soon as the patient arrives with suspecting ICU, we have to start all pre-op workup parallel to the assessment also. Because as early as possible, if we're getting all the results, we could shift the patient for surgery as early as possible. So there should be assessment should start as soon as the patient comes to AD itself. And also...
what complication you can develop after the surgery? Means after this problem in the brain? Any problem, complication?
Scar.
Scar
epilepsy,
that
is not the complication. But that's a complication. But that is not the complication in ICU. What else can occur for the patient who is having intracranial bleed? Suddenly this patient deteriorates tomorrow. What else?
Herniation, uncle.
You have already done the procedure. There is a tube there. Hydrocephalus.
Hydrocephalus.
Is one of the complications which can occur if the patient is not taken care properly. Not taken care of the site properly. Sometimes patient can develop obstructive hydrocephalus. Not very common. But if the patient deteriorates immediately, we have to repeat a CT scan, see what is a CSF, whether the ventricles are dilated. That has to be ruled out.
What's a compelling indication for emergency surgery is one is cerebellar bleed, second is bleed with interventricular extension causing secondary hydrocephalus, which again can cause secondary corning, and the third will be intrahemispheric bleed because there's a large volume of blood going into this thing, so the patient can anytime go into herniation. So these three have to be emergently taken for bleed. It's more like a SH or something. We have some more time, so we can go for coiling or something which we can plan and do. So emergency surgeries will be like in any kind of impending herniation or worsening situation. We have to go for emergency decompression craniectomy.
Which is the most common site of hypertensive bleed?
Basal ganglia.
Putamen.
Which is the most common site for aneurysm bleed?
Anti-communicating.
These are the two things we should just remember. Putamen is the most common site for this patient had the
GC bleed.
Other patients will have most common site is
Anti-communicating.
Anywhere it can bleed.
And if it's an SAH, then we also start with nemodipine. 60 mg. Vasoconstriction, cerebral vasoconstriction, then
It prevents
prevent
vasoconstriction.
That is a secondary event. After the initial event, patient can have vasospasm and further damage to brain tissues. nimodipine can prevent that secondary event and it
Calcium
can
channel
reduce
blocker.
that damage, vasospastic damage to the brain. Okay. So that patient should be started on
Nimodipine.
nimodipine. Okay. That's a calcium channel blocker.
Calcium channel blocker.
Anything else, sir?
So renal functions normal.
Renal function is normal, sir.
This is also more important. I think.
Our blood parameters came back normal.
ECG, everything.
Everything is normal.
Okay, good.
Whereas for mannitol, SNP, all these things we cannot give if the creatinine is very high. So we have to be very careful. Okay? Thank you.
Thank you, sir.